Next up, we will hear from experts about strategies that can prove effective in combating opioid misuse and addiction within the older population. Please welcome on stage Kathleen Cameron, Senior Director, Center for Healthy Aging at the National Council on Aging, Andrew Kolodny, Co-Director, Opioid Policy Research Collaborative at Brandeis University, Cynthia Riley, Director of Substance Abuse Prevention and Treatment Initiative at the Pew Charitable Trusts. The Hills healthcare reporter Rachel Rubine will be leading this conversation. Rachel, over to you.
Hi, good morning. Thanks everyone for being here. Special thanks to our panelists as well. So we've heard a lot about the problem this morning, 14.4 million Medicare beneficiaries receiving an opioid prescription in 2016. So Dr. Kolodny, I'd love to hear a little bit from you about how you diagnose someone who's a senior with an addiction. Just take us through that conversation. I imagine it might be difficult, particularly if it's an older adult who's never had an addiction before.
Yeah, it's a really good question, and we don't have a good way to diagnose opioid addiction. A pain patient on opioids is going to be very highly motivated to hide the fact that they're having trouble with their opioids from their prescriber, because in many cases the patient has tried to get themselves off of opioids and can't. They're worried if they don't get that prescription, what does that mean? Where are they going to go? So it can be quite difficult. One of the problems is that when a prescriber has a concern about their patient, maybe the patient is coming in early, asking for higher and higher doses, the prescriber doesn't want to put a label like addiction on the patient, and the patient will usually explain the behavior as being related to a worsening of their pain. So when the patient gets referred anywhere, it's often to a pain management specialist, and then it's hit or miss. There are some pain management specialists who'll do a terrific job of helping these patients get off of their opioids, and when you can get a patient off of their opioids, you'll often see an improvement in their pain, which can be surprising, and an improvement in their quality of life. But as you heard previously, we've got many physicians out there, pain management specialists, who have no qualms about going even higher and higher on the doses. And something that's not well known is that when you compare opioid overdose deaths in older folks who are able to get pills more easily from doctors, when you compare the deaths in that group to the younger people who more often have to switch to heroin after they become addicted because they have a harder time getting pills from doctors, up until pretty recently, we were seeing far more deaths in the older group than in the younger group. The younger group is now catching up because of fentanyl, but over the past decade, many more deaths in the older people who are becoming opioid addicted to pain medicine.
Mm-hmm. And Cynthia, I'd love to hear a little bit from you about treatment. Are there gaps in treatment for seniors?
Mm-hmm. Certainly. One of the things we know is for all individuals, there is a substantial gap in terms of access to treatment once someone has been diagnosed with a substance use disorder. In fact, only 1 in 10 individuals receive any form of treatment, and even fewer than that receive medication-assisted treatment, the use of medications in conjunction with counseling, which we know is most effective. It can be even more challenging in this population, again, first recognizing the disease, but then there are also barriers in terms of transportation or access to providers that we can see in this population, as well as nationally we have a shortage of both prescribers of those medications, as well as I know there was an audience question earlier about behavioral health specialists, and we are facing significant gaps in the availability of those providers that are key to treatment.
Kathleen, did you want to jump in a little bit? Are there facilities that are catered towards Medicare beneficiaries, seniors?
Unfortunately, there are not enough across the country. There are some models out there, like the Betty Ford Hazelton Center in Naples, Florida, is very well known for providing specialized services for older adults who are addicted to not only opioids, but alcohol and other substances. So that's certainly, I think, a solution to this problem. We need better treatment facilities for older adults that target to their unique needs. And they do have very unique needs, which are very, different from the younger folks who have addiction, those in their 20s and 30s. Yeah, absolutely. One thing I do want to mention is, which I don't think has been brought up, is, over 50% of older adults have some type of chronic condition that results in pain, whether it's osteoarthritis or rheumatoid arthritis, could be diabetic neuropathy, could be cancer pain, could be fibromyalgia. So it's a real problem out there, and we want to make sure that we have a balance in our approaches for treating older adults, but also avoiding addiction.
If I could just say, I think the topic of balance comes up frequently, and the issue really isn't, how do we stop people from abusing these pills while prescribing them for everyone who might have a pain problem. For many of those conditions you just mentioned, especially fibromyalgia, we should not be giving opioids. These are good medicines for end-of-life care. They're good medicines when used for a short period of time after major surgery. And they're good medicines for some people with chronic pain if they're taken on a low dose on an intermittent basis. The senior who can make one prescription with 30 pills last several months. But when they're prescribed to be taken every day, round the clock, these extended release formulations, it's a recipe for disaster.
Cynthia?
Yeah, and certainly, it's important to recognize that we don't have perfect therapies for this population, and there are other choices we can make, but then again, we have conditions such as chronic kidney failure that can influence your ability to use something like a nonsteroidal. One of the things we do know, there have been studies that have shown in the elderly population that individuals that are using an opioid for pain are up to 5 times more likely to fall and experience a fracture. And certainly we know the implications of that in an older population, but they're up to 5 times more likely to experience that event than their counterparts that receive a nonsteroidal.
And so older adults, just are more susceptible to chronic pain. So right now, what's sort of the state of research for non-opioid alternatives to treating that pain?
Well, you'll often hear that we need to be spending more money on research so that we've got alternatives to opioids. But the truth is, for the vast majority of people who suffer with chronic pain problems, we already have non-opioid medications that are effective, and we have non-pharmacologic approaches that are effective. So, it's always great to look for more options, but as the era of aggressive prescribing kicked in starting in 1996, as we started to prescribe more opioids, we began prescribing less of the non-opioid medications, and we began referring patients for non-pharmacologic approaches less often. So we need to shift back to using non-opioid pain medicines and treatments more often.
Kathleen, did you want to jump in on what you've been seeing on this?
Yes, I would love to. At the National Council on Aging, we focus on prevention and wellness. And we know that there are evidence-based programs that can help prevent people from becoming addicted, something like screening, brief intervention, and referral to treatment, which involves motivational interviewing with older adults. It's used across the age span, but there are numerous studies that shows that it's effective in older adults in preventing abuse and addiction for alcohol and substances. So that's one approach. We also promote evidence-based programs around chronic disease management, including a chronic pain self-management program that's been shown effective to activate patients, to put them in the driver's seat, give them control over their health condition. They become better communicators with their healthcare providers. They ask the right questions. They ask questions about therapy that's prescribed. They understand their therapy much better, and they look at non-pharmacologic approaches to managing their chronic conditions, including chronic pain. And that could be things like physical therapy, exercise. Tai Chi has been shown to improve pain for many older adults, particularly those with fibromyalgia. And so there are lots of non-pharmacological approaches, as you've been talking about, that we need to promote. And we need more funding for those non-pharmacological approaches, a better workforce to deliver these programs. Right now, we're very limited in the funding, like for the chronic disease self-management program. Most of it is funded through the Older Americans Act, so we need to better integrate these programs with healthcare.
And Cynthia, maybe you want to take this one, but what else is needed from Congress or the administration?
So one of the things that's really important here is that we need to identify these individuals that are at risk early. The earlier that we can identify someone as potentially receiving high doses or dangerous combinations of opioids and other controlled substances, the better we can do for these patients. The more quickly we can help them address their pain management, the more quickly we can identify the potential presence of a substance use disorder. Pew has done extensive research on the use of patient review and restriction programs. They're also called lock-ins, but we've done research on the use of these programs, which have been very effective on the commercial side as well as in Medicaid. In terms of identifying patients early that are visiting multiple prescribers or multiple pharmacies and singling out individual caretakers to help manage individual prescribers or pharmacies to help better manage that care. Just recently in the Comprehensive Addiction and Recovery Act, the authority to run those programs was extended to Medicare. So they have that authority now, but we're waiting for regulations from CMS that will tell plans how they can go about implementing those programs. And those can be a significant step in terms of the early identification of patients that are either already suffering from a substance use disorder or maybe at risk.
I would agree with everything Cynthia said. I think when we talk about solutions to the opioid crisis, we really have to begin by framing it the right way. And we've heard today the terms misuse and abuse used frequently. Our opioid crisis is not an abuse epidemic. It's not an epidemic of people taking dangerous drugs because it feels good and they're accidentally killing themselves. The opioid crisis is an addiction epidemic. It's true that some people became addicted because they were taking opioids to enjoy the effect. Many people have also become addicted taking opioids as prescribed by doctors. Once somebody is addicted, they're not doing it because it's fun. They're doing it because they have to keep doing it to avoid feeling awful. So the reason the nation is experiencing record high levels of opioid overdoses, the reason we're seeing heroin and fentanyl flood into non-urban areas, the reason we're seeing a soaring increase in infants born opioid-dependent, children winding up in the foster care system, outbreaks of injection-related infectious diseases. The driver behind all of these health and social problems has been the very sharp increase in the number of Americans who are opioid addicted, an increase that began in 1996 as the prescribing went up. We created an addiction epidemic by overexposing the population to these highly addictive drugs. So if you frame the problem as an addiction epidemic, what you need to do about it becomes much more clear. We have to respond to this problem the same way we would respond to other disease epidemics. You respond by containing it, preventing more people from getting the disease, and by seeing that people who have the disease receive access to effective treatment. And to prevent more people from becoming opioid addicted, more than anything else, that really boils down to getting the medical community to prescribe much more cautiously so that we don't directly addict our patients and so that we don't indirectly cause addiction by stocking everybody's home with a highly addictive drug. But as was mentioned earlier, the genie is already out of the bottle. Millions of Americans are now suffering from opioid addiction, and we can curtail the overprescribing, but if we don't see that the millions who are addicted, that they can access effective treatment, if we only curtail the overprescribing, we're going to have to wait for that whole generation to ultimately die off, because they will continue using, and we'll see heroin and fentanyl continue to flood in. So we have to see that they can get treatment. That will require a massive federal investment. We're going to be hearing this week, I believe, from President Trump, who will be announcing an emergency designation, hopefully, What should be included in that designation is a very large investment, I believe in the billions, so that we can build out a treatment system that doesn't exist yet. What we want at the end of the day is for someone who's opioid addicted, when they wake up in the morning and they know they're going to need to use because they're going to be feeling awful very quickly if they don't use, you want that individual to be able to walk into a treatment center, get started on treatment that same day, regardless of their ability to pay for it. You want that treatment to be easier to get than pills, heroin, or fentanyl. And if we don't get to that point, I believe that overdose deaths will remain at record high levels.
Mm-hmm. And Kathleen, you also mentioned funding. You know, let's say we do get that federal investment. What do you think that funding should go to in terms of seniors? What sort of first step there?
Well, for appropriate geriatric care, you really need integrated and coordinated care. So expanding some of the models like accountable care organizations that really integrate primary care, even mental health, but also bringing in care in the community that's provided by the Aging Network. You know, those who are delivering meals to older adults, who can spot changes as older adults maybe become addicted. There are certain signs that they can be educated on, that they can work with healthcare providers to provide information about and educate older adults. So there's, you know, in addition to meals programs, there are also other people going into the home who need to be educated about what to look for with older adults. But again, that integration of mental health with community care and with primary care is really critical so that we can have a much more comprehensive, coordinated, collaborative approach to care for older adults. So looking at new models of care that really address the broad array of issues that are facing older adults.
Mm-hmm. One of the things that's really important here that's been touched on is that how important it is that we consider this a disease, right? There's still substantial stigma associated with substance use disorders, and it's part of the problem. In fact, the reason we're having this discussion today, and there are many probably in the audience or listening online that are surprised that this is a problem in the elderly, because at its heart, we still often sometimes look at this as a moral failing, and it's not. It's a diagnosable disease that we are able to treat.
Yeah, there's a lot of shame for older adults about this, and many of them remain isolated, become depressed, which only exacerbates the problem. They may be treating that depression with opioids or other substances like benzodiazepines, which are also highly prescribed and highly addictive for this population. So reaching out to those who are isolated is really key.
And how do you combat that stigma or alleviate that shame that might be in the older adult community, do you think?
One way is to let them know that they're not alone. There are others with this experience, and that there are treatments available for them that are accessible for them. Yeah, I think that's one way that, they're not alone. Yeah.
And we just have a few more minutes, and we'll take audience Q&A, so start thinking of some questions you'd like to ask our panelists. Cynthia, I'd love if you could talk a little bit about electronic health records in the Medicare beneficiary community and how that could help, or what the state of that is for opioids.
So there are two components of that. First, there's the electronic health records, and we heard a little earlier about e-prescribing and the potential for that in this population to, just ensure the integrity of the prescription. In addition to that, sharing information across providers that a patient may see that you can achieve through electronic health records. Another area, and it's been talked about a bit earlier today, is prescription drug monitoring programs and the ability to use those systems to identify patients earlier on that may be at risk of harm or risk of misuse of these therapies. And so we do have just about every state now with a prescription drug monitoring program, but we need to increase use of them and address some of the workflow barriers that exist in terms of prescribers using them. Not only putting it integrating that information within the electronic health record and HIT, but also making the display of the information easier to comprehend. So in a busy setting, emergency department or a patient care setting, a doctor has, or a nurse practitioner has just a few moments to look at that information and make a prescribing decision. So how can we help them do that? How can we present the information or manage the information in a way that makes it most useful and easiest to comprehend is important.
And Dr. Klodny, real quick, do you think physicians are using the prescription drug monitoring programs?
They're not. Where you see prescribers use a state PDMP before prescribing is in states where use has been made mandatory. In states where it's up to the prescriber, utilization is extremely low. Sometimes in emergency rooms, if there's an ED doc who thinks they saw that person in the ED last week, they'll look at the PDMP and sort of a game of gotcha will ensue. But when it's up to general primary care docs to check, they don't do it. Unfortunately, many prescribers think they can tell by looking at someone who may or may not have a problem, and of course, they can't. So use of PDMPs must be made mandatory. And in the states where use has been made mandatory, you've seen a very sharp increase in utilization of the PDMP and a significant decrease in both what's been termed doctor shopping, but also you see a decrease in the casual prescribing when a doctor has to take a couple of extra, a minute or two to check, especially dentists. You start to see that they prescribe Advil and Tylenol more frequently when they don't want to have to do the extra work to take a look, and that's a good thing. We start to see reductions in casual use.
Thank you. I think we'll turn it over to audience Q&A now, if you don't mind identifying yourself before asking a question. Over there in the back.
Yeah, my name is, I said my name a while ago, but I'm Ana Veria from the Department of Behavioral Health. I appreciate your recommendations for integrated medicine. But I haven't heard about the peer support services. We have mentioned about lack of workforce and related factors, but the CMS nowadays have recognized the peer support services and then as an evidence-based practice using people who have been sick themselves and training them and helping navigate the healthcare system and supporting the people who are in the nursing homes, in mental health clinics, in emergency rooms have been very effective. We have tried it here in DC, and we have found that it has really been a tremendous support to our healthcare providers by people who are in recovery, helping others who are in their present context of illness. Just want to put that in.
Yeah, and Kathleen, do you mind talking a little bit about the status of peer support services?
Yeah, one of the programs that I mentioned, the chronic disease self-management education programs, and there's a whole suite of programs that were originally developed at Stanford University. They are peer support programs. The facilitators or leaders of the programs are people who have chronic conditions, who have been trained to deliver this program and to meet with a group of older adults or others with chronic conditions and help them work through their chronic conditions. A lot of problem solving that takes place, decision making, and really group support. So I think you're referring to a similar type of program, and these programs have been well researched. They've been shown to improve healthcare outcomes, patient satisfaction, and they save healthcare dollars in the long run through reduced hospitalization and ED visits.
And Cynthia?
And so peer support is obviously a key intervention that can help address this issue. One of the things that we see a lot of is in the emergency department where peer support is brought in to work with an individual who may have just experienced an overdose. It's obviously a teaching moment. It's a key, actually, in this population.
Yeah,
one of the things that we know from recent data from the Agency for Healthcare Research and Quality is that We've seen a significant rise in hospitalizations that have been paid for by Medicare. So right now, about a third, and opioid-related hospitalizations. So right now, a third of all opioid-related hospitalizations are in the Medicare population. They are the payer for that. So it's a key population where that intervention could prove very helpful.
And unfortunately, we're out of time, but thanks everybody for a great conversation and for being here.
Thank you to Rachel and our panelists. That brings us to the end of the program. On behalf of The Hill and our sponsor, SureScripts, I'd like to thank you for joining us. If you've missed any portion of the event, it will be on a video on thehill.com later today. And just a reminder to fill out your surveys for feedback. Have a wonderful rest of your day. Thanks.